Hello all. I'm so excited to have you all here today to attend Stop TB Canada's webinar, Words Matter. Our discussion today will center on stigmatizing and empowering language while talking about tuberculosis. And our focus today will be on TB impacted communities in Canada. Before we move ahead, let me quickly introduce myself and give you all a brief outline of the agenda today. I'm Ektan John, the Global Health Policy and Advocacy Manager at Results Canada, a not-for-profit organization that envisions a world without extreme poverty. In this role, I'm also a member of Stop TB Canada's Secretariat team. So Stop TB Canada, as some of you must be aware, is a network connecting people, organizations, and communities committed to ending tuberculosis in Canada and abroad. You can join our email list and a directory by using the link my colleague and fellow Stop TB Canada member, Lee Rathby's post in the chat. Today, we are going to do a deep dive into the recently published Words Matter, a flagship language guide developed by Stop TB Partnership, and discuss its applicability and what it means in practice for those living with and working in TB in Canada. The report reflects the strong role that words can play to empower and end the stigmatization of those affected by TB. Most importantly, I think it encourages global participation needed to combat this deadly disease and reach the TB target and goal to end TB in time for the 2030 deadline. To discuss this, we are joined by a stellar panel today, which includes voices and perspectives from communities disproportionately impacted by TB across the world. The discussion will be moderated by Stop TB Canada's co-chair, Tina Campbell, who's also an advisor at the Northern Intertribal Authority, and she has worked extensively with Indigenous peoples in Canada. So a brief outline of the agenda today. The moderated discussion will be for 50 minutes before we open the floor for questions. We will also conclude the session with an exciting announcement, so wait for it till the end. In the meantime, feel free to introduce yourself in the chat and use the space to post questions for our panelists at any point, or to share an experience that you've gone through where vocabulary has impacted you in conversations regarding TB. So please feel to use the chat space for that. And with this, I'll open the floor and I'll let Tina take over. Over to you, Tina.
Hello, good morning, everybody. Thank you for joining us today in this very important session. Over the next 15 minutes or so, we'll get each panelist to do a little brief introduction of themselves and the work that they do. So first, we'll start with Rhea. So take it away, Rhea.
Thank you, Tina. Thank you, Stop TB Canada, for having me. I'm really excited to be here. A quick introduction myself. My name is Rhea Lobo. I am a person who has been affected by TB. I had extrapulmonary TB a few years ago, and I went through hell with my experience. And since that experience, I've started talking about it. I am currently a board member alt at UNOPS's Stop TB Partnership for the Communities Delegation. I'm also part of the team that's made the global plan to end TB by 2030. And I am, in my day job, I am a filmmaker and a communications consultant for a number of organizations, including public health organizations like the Union and consulting organizations like Dalberg Media. So thank you very much for having me. This is a very, very interesting webinar because I think words have the power to change the response. And I think there's not been enough attention given to how we speak about TB and how we speak about TB to people affected by TB. And I'm glad that a little less than a decade ago, we started taking this a little seriously. And we had the first edition of the Words Matter Guide, which was called Every Word Counts, that was launched in 2013. And this is pretty much a follow-up to that, version 2.0, that was built up on this guide. Now, this is an extremely important guide for many reasons. Strategically, because we had a UN high-level meeting that happened in 2018. We're going to have another UN high-level meeting happening in 2023. And I think it's important that we are careful with how we speak about TB and make sure we use unified language, and this guide is sort of a sort of, I mean, like it is a guide to that, right? And it's response to the needs of the affected community. It's unifying that vocabulary to make sure that we're all united in our response. So, and this is an extremely important part of why this guide is very, very important. The second thing I want to say is the guide itself is not just somebody woke up one morning and said, okay, I'm going to write this guide. It was an extremely collaborative effort where we had stakeholders from across the table. Like we had researchers, we had people affected by TB, we had regional consultations across the world with organizations like TB People and the America's TB Coalition, for example, leading these regional consultations. We had researchers, scientists, everybody was involved with formulating this guide. So in that sense, I think it's an extremely inclusive guide and a very, very important one. For those of you who haven't had a chance to actually read the guide is divided into 3 portions, and each is as important as the other. But my most favorite part of the guide is really the language guide, which is the second part of the guide, where it tells you what you should absolutely not use, words that you should absolutely not use, and words that you need to be careful about using. And it's sort of like it talks to you in a way where you can completely relate. For example, if I mean, for all of you who work in TB, you know that TB treatment can be very long and very tiring, and at the end of the day, it's not it's not our fault that it's long and tiring, but then we'll be called defaulters if we miss not taking the pill for a day or two. So it's just, I think it's important that we're sensitive to this language and not use terms like defaulters, and use, I mean, and the guide provides alternatives to that, and we need to be cognizant of that. So, I mean, I just noted down a few words that I found very interesting that we should not use. Okay, something like TB contact. We shouldn't say TB contact. We should just say contact, and we shouldn't say defaulter. Like I said, we should just say people lost to follow up. And notice how the language is so human. We shouldn't say a word like suspect. I mean, suspect sounds like that's a TB suspect. I mean, what, like, who says that? I mean, you should not say that. You should say people with presumed TB, right? And TB control, and instead of TB control, you should say TB prevention and care. So it's just these little bits of words, and you notice how just by just talking more humanly and more humanely, it makes a world of a difference to the person who's receiving care, because at the end of the day, you're also empowering that person to take control of their own health and their own lives, rather than make them passive, recipients of care. You're making them empowered individuals who, are equal partners in the response. Yes, that's about it. Thank you, Tina.
Perfect. Thank you, Rhea. Next, we'll get Beauty to do a little introduction.
Thank you, Tina. Hi, everyone. And Rhea has just started off so wonderfully. So I'm basically doing work. I'm researching on how language impacts TB care. And as a social linguist, my background is in social linguistics. When I came across word matters, I think the document, I found it last year, and I was like, okay, this is very interesting. I appreciate the fact that we acknowledge that words matter, because they really do. And the words that we use, language is like the most powerful tool that we use to construct social realities. And that means that the choice of one word over the other impacts people differently. It may empower people or disenfranchise people. So it's very important that words are chosen carefully. And my primary interest in TB research is basically how we can reframe words that are used in TB discourse, both in scholarly settings and also clinical settings. That way, persons affected by TB or persons with TB may also be able to be part of the discussion. And also, as Rhea said, some terms, one that actually struck me was TB suspect, but another one is vulnerable populations. For me, I just think words, I know that it's not in the TV guide, but that is one word that I've problematized over like my course of doing research recently, and looking at some of the works that have been published in academia. I've also identified some words that are problematic. So my research is mainly to look not just in social discourses, but also in academia as well, in policy guidelines. What are the words that are used? How do they impact people who want to seek care? And how do these words empower people to actually take control of their lives? And how does it promote stigma? Because as we know, stigma actually is a challenge in TB care, and not just TB, in health as a whole. So people who are struggling with stigma are disenfranchised in a way. And my work is to eliminate how these words can be reframed so that people affected by TB can actually be the center. They can feel compassion when they are, when they seek care, and they can actually take full control of their lives, and we can end TB eventually. So that's just me in a very short way of putting it.
Perfect. Thank you for that, Beauty. Next, we'll get Tiffany to do a little brief introduction of herself and talk about Indigenous perspectives and experiences with language and TB care. So Tiffany, take it away. I think you're on mute there, Tiffany. We still can't hear you. Nope. Okay, she's gonna try and talk. Oh, but it's gonna.
Can you hear it now?
It's muting. I mean, sorry, 1 second, guys. Okay, are you guys able to hear her, Tiffany?
Pardon?
Yeah, they can hear you. You can go.
You can hear me now? Okay. Sorry about that. My computer's acting up here. My laptop at work at home. So, good morning. Hello, my name is Tiffany Adam. I'm an Indigenous woman of Dene ancestry from Treaty 8 territory here in northern Saskatchewan. I've lived the majority of my life in Fort Smith, Northwest Territories, and I am the eldest of 4 siblings. I'm a mother of 2 amazing, respectful, responsible children. My daughter is currently 20 and my son is 14. TB is no stranger to my personal history or home. However, before moving back to Saskatchewan from the Northwest Territories, I was surprised to find that TB was still thriving here. My dad is a survivor of TB sanatoriums where he remained for years as a child. Additionally, I was sent to Uringan City Hospital without parental presence for treatment of TB. I was probably less than 5 years old at the time, and I remember feeling scared, unsure of my surroundings. I was confused, and as I didn't understand English, English is actually my second language, and that it was my first experience of being forced to eat food, probably to give the meds. Prior to that, I don't recall being forced to eat, let alone something that I wasn't familiar with. Moving forward to today, I have been a registered nurse for 15 years. All of my career, with the exception of the first 2.5 years, have been dedicated to northern Saskatchewan in many roles, including primary care, supervisory roles, as well as home care and public health. And this is to include the TB program. I joined Northern Intertribal Health Authority in January 2021, first as a CDC nurse, and then I was offered a position as a TB nurse, which allowed me to return to frontline work and visit our northern communities.
Perfect.
Can you hear me?
Yeah. And then you can move on and talk about a little bit of the history.
You want to go back? Okay, I'll go into the history then. So just a little bit of history of TB and Indigenous populations. What I'm about to discuss surrounds tuberculosis, sanatoriums, residential schools, intergenerational traumas, and this may be triggering for many. As a reminder to practice self-care, reach out and talk to others if you need to decompress following this discussion. For most people in Canada, the risk of developing active TB is very low. However, the rates of active TB are higher among Indigenous peoples in Canada. As stated by the Public Health Agency of Canada in 2017, the reported rate of active TB in First Nations is over 40 times higher among First Nations living on reserve and than non-Indigenous Canadian-born people. Epidemic tuberculosis came to Canada with European settlers in 1700s. TB was spread to the First Nations and Métis people on the prairies about 130 years ago when the Canadian Pacific Railway was being built and the reserve system established. The Dene and the Inuit in the north were exposed more recently in the late 1900s to early 20th century. Malnutrition increased the risk of disease, and the confinement of First Nations people on crowded reserves allowed the disease to spread rapidly. Tragically, TB death rates among children and residential schools were even worse, as high as 8,000 deaths per 100,000 children. When tuberculosis epidemic spread among the northern Inuit communities in the 1950s and 1960s, thousands were transported to southern hospitals and sanatoria for treatment. At least 1/3 of Inuit were affected by with TB in 1950s. For First Nation communities in southern Canada, this was similar, that people were screened for TB on reserves and sent to sanatoriums hundreds of kilometers away without any notice to their families. Speaking to the survivors, we have learned that some people sometimes assume that one would not come back from the sanatorium. And just going back to my dad's experience, like he did go out there and he came back, and there was that stigma to him as to what it was that he was carrying, the stigma of being in the family there. Just like residential schools, TB sanatoriums and Indian hospitals serve as a form of segregation. Parents of children who were made aware of the transfer of the children between these institutions, experimental treatments and procedures were common practice. These stories and experiences are what shaped a lot of resentment, mistrust of any institutions today. Today, a lot of First Nation Inuit Métis members are still living in remote and isolated communities or reserves that continue to face inequalities. As reported by Statistics Canada, 37% of First Nations living on reserves reported living in crowded households, compared to 8% of the non-Indigenous populations of Canada. The ongoing housing crisis in our communities and housing conditions such as poor ventilation and air quality in the home can increase the spread of the illness. This is a big factor in TB transmission within the household. Housing units may not be built adequately to withstand the weather or elements, and the people are forced to board up the windows to keep the heat in and the cold in the colder months, and air is circulated and trapped within that home. In addition, TB is heavily stigmatized. Some people think TB is a disease of the people in poverty, substance users, or with people with HIV. Negative experiences may form views of TB within a family unit, and that this view is passed down from generation to generation. And that's pretty much all I have there.
Okay, perfect. We can move right on into our panel discussion. We do have, let me see, sorry. Thank you, Tiffany. We do have, is it 15 minutes allotted? Jeez, sorry, 15 minutes allotted for our panel discussion. So as I'm asking questions, just remember to keep your replies kind of short, and so we can move on through all questions and then get to questions from the audience here. So I'll just get Elizabeth to introduce herself before we get started.
There we go. Hi, everybody. I'm Elizabeth Ray. I'm the other co-chair of Stop TB Canada with Tina. I'm also a public health physician working with the tuberculosis program in Toronto for a long time. And I'm very happy to be part of this webinar today.
All right, sorry about that. Okay, so for the first question, this question is for Tiffany and Beauty. As someone who provides care to communities impacted by TB in the North, how do you feel about the language recommended in the guide? And I'll get Beauty to answer that question first.
No, I thought about that question. I thought I don't provide care for people in the North, but I think I'm just gonna let Tiffany take that question, and then I'll take the second one because I don't have lived experience of that.
All right.
Tina, you're on mute. Tina, you're on mute.
Can everybody hear
Yeah.
Tiffany again? All right, so as someone who provides care to communities impacted by TB in the North, how do you feel about the language recommended in the guide?
Given the history of the TB sanatoriums and history of child apprehensions, Indigenous peoples continue to have a stigma attached with the TB program, feeling such as the program not being one of support and fearful, and try to protect their family home and of TB treatment. The language guide is important, and the document is a great place to start, especially when caring for Indigenous populations. We have to first be aware of the potential stigma and have cultural competency training, and to be aware of what inequalities Indigenous people face today, which contribute to overall health, housing, access to healthcare, food insecurities, language barriers. A lot of our Indigenous do not have distinct medical terminology in our languages, making things easy to understand in one thing, and is also using terms that do not give them the diagnosis of TB as something negative is also important. I think the next step would be to review the TB programs that care for Indigenous populations and review and adapt something similar.
Perfect. So while I have you on the phone here, I'll just ask you the second question and then I'll go back to Beauty. So is there anything in the document, is there anything the document has missed and you would have liked to see included?
I feel that it's important that in the future that the document is introduced in the Indigenous languages. Interpretation of medical terms in English is much different than that of in the Indigenous language. The interviewing process and all that kind of stuff guides us. We're expected to have open-ended questions, whereas in Indigenous languages is very closed and is very direct. As far as the documents now, I believe that obvious is that we need to stop, that we need to move now and make the changes in the language starting now, and starting with our own provincial program, from TB prevention and control to TB prevention and care, which is also mentioned in the language guide. And quite honestly, like as a healthcare provider, going in and talking to the clients, our patients, and talking about the collaboration of care, and then using the word control in there doesn't settle very well. Just kind of, it's uncomfortable to use that word in caring for people.
Perfect. Thank you so much, Tiffany. So I will move on to Beauty. Is there anything in the document that the document has missed that you would like to see included?
Tiffany mentioned a great point about the consideration of other languages. I would also want to touch on that. I was going through the document and I thought about the words in African languages, for example. And I thought if we have to directly translate this, specifically because most African languages do not have like scientific terms, like a term for scientific words, you know what I mean? So, and I thought about the fact that if we're to directly translate this to African languages, how accessible or how easy would it be to use that kind of language in communication? So that I would like to suggest like consideration to context. I know that it's Stop TB Canada, but these documents can go beyond the North to other parts of the world, and not just in Africa, other parts of the world. Perhaps the language issue might be a problem when we speak of Indigenous languages, and also the practicality of the terms in actual settings, for example, in clinical settings. I thought about that. Yeah, that's something that came to mind when I went through the document. Also, another word that I'd like to mention is vulnerable populations and high burden country. What is the other one? Just one moment. And the other one is disease of poverty. It would have been great to see like a suggested or preferred term to replace these terms, although they're not like as problematic, but in other contexts, again, I'm going to go back to Africa. in those places, these terms are problematic, and just including them and having like more empowering words to replace them would be great. Yeah.
Perfect. And another question for you, Beauty. Given your work on the role of language and generating stigma, how important is this guide in ending TB stigma, and what could be improved?
Okay, I sort of touched on what could be improved, so I'm just going to touch on the other one. You know, I was thinking of something that happened to me a few months ago with a colleague that I was speaking to. So I said, "Oh, I hope my headache goes away so I can speak to you." And then like my colleague went, "It is not your headache, it's not your disease." This is just to tell you how important words are in different contexts, right? So that's why it's really important to have this sort of document and to show how we can use, when you use one word over the other, the kind of impact it has on people. So it's very important to have this kind of documents, especially for destigmatizing TB care. You know, a lot of people associate certain words with certain things, and this also disenfranchises people, which is a problem. So this is a very timely and important document for my work, really.
Perfect, thank you. So moving on, Elizabeth, do you think a Canada-specific, context-specific versions of the guide would be available?
Well, I don't know about available, but in terms of would they be used, I think touched on some of the Indigenous dimensions of talking about. We've also multiple languages who get other languages are part of their daily lives. So, you know, that the about, you know, we think about translations into other who get sick with TB and born outside of Canada, came to Canada, often speaking more than language beyond English or French. So that's absolutely relevant. And another example of that, bunch of words, say born, like foreign-born TB, and the used in data is Aboriginal TB, Aboriginal, non-Aboriginal TB. So that's, you know, maybe kind of something that's a little bit specific to terminologies that's just kind of been around for a long time in Canada, but it's an example of something that would be, I feel like, useful to tackle. So I'm voting yes for some additional words that are maybe more specific to different contexts in Canada, or even specific places in Canada. We're a big country with many cultures. So I like the way Rhea was originally talking about this document as a guide, not the be all and the end all, but a solid place to be thinking about how we use language.
Perfect, thank you for that. And I apologize that it wasn't available. It was valuable, was the word I was supposed to ask. So my next question is for Rhea, sorry. Has the need for a context-specific language guide been raised during consultations for Words Matter?
Thanks, Tina. I just wanted to start with an anecdote, actually, something that I experienced when I had TB. I went to the doctor, and when the doctor told me that I had TB, one of the things he said was, "How did you get it? It's a poor man's disease." And I was like, "Say what?" Like, and then he said, "No, because I mean," and then I actually went a little back, and I was talking to my cousin who was studying medicine, and he said, "Yeah, that's what we're taught in our textbooks, that it's a poor man's disease, in medical school." And that itself is reinforcing stigma in so many ways, right? And I think, like Ray said, there is this document is a living document. It's not something that is, okay, here we are and this is what you need to do. This is something that is constantly adapting, constantly evolving, and something that we need to be constantly responsive to, and I want to get back, before I answer the question, Tina, I wanted to get back to why we have this document to begin with, right? It is to empower people who have TB, who are living with TB, who are affected by TB, right? It is to empower them, to make sure that we talk compassionately and openly about TB, and to ensure that we have a human rights-based approach to TB, an environment where we're encouraging innovation and we're not stigmatizing people who have TB, and I think, at the very core of that is, what happens in India is very different from what happens in Toronto, and very different from what happens in Copenhagen, where I am right now. And I think it's very, very important for us to understand the nuances of language, the nuances of culture, and also context, right? These are the three bits that we really need to, dig deep into. And I would really encourage partners and people who are going to adopt this guide to sort of make this suit you, and with the core concept of keeping the person who's affected by TB at the heart of it. Would you like to be called a defaulter? Would you like to be called a case? Ask yourself that question. It's not really rocket science to change that word a little bit, to just make it sound more, because already a person who's going through TB is going through so much. It's not like we have a level playing field with TB at this point, right? And I think one of the things that, and I think COVID in some ways has helped us understand this, that, infectious diseases, they're in the air, right? Like, I mean, anyone can get it, right? And it's time we break all these barriers in terms of how we refer to, people who are affected by infectious diseases, and just be more compassionate about it. So definitely, I don't just think it should be language and context and culture that we need to be cognizant of, but also, different stakeholders, like the medical community. I think they should create a guide just for themselves, something which takes a lot from this guide, and then, there's a lot more words we need to address, in the medical community. So it's I think it's also stakeholder based. So that's my 2 cents on it. Thank you.
Perfect. Thank you so much. So our next question is for Beauty, Elizabeth, and Rhea. Terminology can be slow to evolve, especially when ingrained in national health systems, long-standing reporting guidelines, and standardized definitions. What barriers do you foresee in the widespread uptake of the recommendations in the guide, and how can we address them to make sure the TB community as a whole, not just TB advocates, but also TB researchers, practitioners, etc., adopts non-stigmatizing language? So I'll get Beauty to answer that one first, and then we'll move on to Elizabeth.
Thank you, Tina. What comes to my mind right now is just, I had a presentation, a talk some time ago, and a question similar to this came up. And the argument was that words such as patient, cases in the clinical setting is just practical, and it's just a quicker way of getting things done or getting things said. And that is going to be difficult and challenging to actually change that. And I asked, but if we use a different word, would the communication still, would you still understand what you're saying? And the answer was yes. I'm like, okay, so what's the problem? Is it just changing the vocabulary that is the problem? And the room was quiet for a bit. But going back to this, I think that would be a barrier with people with old habits who want to say, okay, no, it's easier to say this word in a clinical setting, for example, than to say this other word because it's too long or it's too problematic, which is some of the things that I've heard when I present in some seminars. But like I said to that person who asked the question, we have terms. Yes, they're technical terms that should be used, but if the terms leave the context, if they can leave the context to other settings where they can be misinterpreted, even though you understand it differently, then it's a problem. These words need to change. So I'm hoping that somehow, specifically people in clinical settings like paramedical people would adopt the change and reframe the use of languages, because right now with social media and even open access journals, so you can't even say this is a technical term for the academic community alone, because it has the potential to leave that community to a different community. And when it gets there, what impact would it have? So that's my contribution to that question.
So, so I want to pick up on one of Beauty's points about technical language. So one of my big bugaboos is the whole thing about TB control. 4 years ago, Canada signed the UN Declaration to fight tuberculosis and signed on to the whole idea of TB elimination, which means even on technical grounds, so, you know, like the epidemiologic meaning of control, well, there is no acceptable level, or there shouldn't be any acceptable level of suffering and illness from tuberculosis, especially in a place as wealthy as Canada. We should not have, even on the technical meaning, we shouldn't have any TB control programs in Canada. If anything, we should all be working in TB elimination programs. So even on a technical count, that doesn't make sense. The word elimination has its own kind of baggage. I'm not really proposing that we, you know, put signs on the door that say TB elimination program, but I just to follow up on Beauty's point, there are a bunch of technical terms even that we use just because we always have. And that's another point that I want to make. There are many things that lead to TB that are kind of bad things in many ways related to TB that TB programs don't have control over. We don't, by and large, have a lot of impact on housing, for example, crowded, underventilated housing. We know it's a massive problem. We don't have direct control over it. We do have control over the language that we use. We absolutely do. If we want to change the vocabulary on the official epidemiology reporting forms, we can. You know, that is absolutely within our power to do. I'm going to make a call out to the Public Health Agency of Canada here, which is folds up the national surveillance data. If they change the terminology on the national reporting form and they report out on different labels, then the vocabulary will have changed. It's that easy. You know, so there's a bunch of stuff that we just need to decide to do it, and it's done. There are kind of, in practical terms, there are layers, right? There's things that are public facing, and I think that point was made before, and I go back again to what's the label on our programs. Like, we could honestly, by September, we could change the names of every TB program in Canada if we wanted to. It's, you know, so there's a challenge for everybody. And then there's also, you know, information handouts about tuberculosis. There's public awareness information about tuberculosis. Then there's another sort of internal layer, our own kind of policies and procedures and training materials. What do we have written down for ourselves? And then there's the daily language use. And that's where some of the other issues that Beauty talked about are, you know, we have language habits, and it can be harder to train ourselves out of that. I think part of the answer to that is for one, we talk about, you know, walk the talk. This is one of those situations where it's the other way around. It's like talk the walk. You know, most people who work with TB they're not intending to be stigmatizing. They want to be supportive, right? So this isn't something, you know, if you say TB control, it doesn't mean you're bad. It's just you can be more effective if you change the words. So program managers and clinicians and supervisors talking that walk in their daily conversations can have a big impact. I think so can having conversations at a team level about, so what kind of language do we want to use? Beauty brought up the point about some terms in the guide are kind of long. They're a bit clunky. And many of us, when we're, you know, in the hurly-burly, we try and have shorter phrases or shorter words. So trying to have some consensus in the team about, okay, well, what's a less stigmatizing way that we can say this that we think is manageable in our daily life? So those are the things that occurred to me thinking about this.
Perfect, thank you. Rhea, do you have anything to add to that?
Yeah, I mean, I'm really enjoying this discussion. One of the things that come to mind is, you know, there's so much of conditioning that happens in global health, you know, where we're just, you know, we're used to saying patient, so we will always say patient. And I tend to think, you know, I mean, as a parent of two kids myself, I think parenting is something that is constantly evolving. So what you could do 10 years ago, you can't really do anymore now, you know. And I really want that kind of approach in global health in terms of, you know, we need to be sensitive to how we talk about people who are affected by diseases, right? And the great thing about this guide is it involved a whole range of stakeholders, including a lot of technical writers and the scientific community, right? And so we sort of heard what they had to say, and the guide was created keeping them in mind as well, right? And there's actually this page in the guide which talks about technical language and conversation language, you know, and sort of, you know, says, you know, there is a difference. And, you know, when you talk among your researchers, you want to talk, okay, you want to say these words, but the moment there is a person from the community in that room, you need to be sensitive to their needs, right? And in that spirit, and just back to the point I said before, I think we really need to contextually develop guides and make sure that the spirit with which we're developing these guides keeps the person who's affected by TB at the center. The second point I want to make is, you know, the national, I mean, what is the dream for this guide, right? That program, NTP managers, national program managers, TB program managers, just take it and just sort of embrace it and use it in all their policy documents, use it everywhere, so that, you know, it sort of seeps down to the healthcare worker who's directly interacting with people affected by TB, right? That's the dream, right? And in order to do that, I think it's very, very important that NTP managers actually invest in understanding this guide, and not just like, okay, guys, just read it, but like, you know, contextualize it to language, to cultures, and sort of adapt it for that purpose, and make sure that even in the spirit of, you know, that language has the power to, can empower people, right? And we need to make sure in the scientific community, in the civil society community, in all these communities, that this language, in the spirit with which we are aiming to, you know, what we're aiming to do, it somehow gets adapted in the mainstream and gets operationalized, and we change the way we talk about TB, not just in discussions like this, but also in conversations on, you know, resource mobilization, and conversations on, you know, in the House of Parliaments, you know. I mean, it has to reach those levels, right, where we just change the way we talk about TB.
Perfect, thank you for that. It is 9:51 here. And we have about 10 minutes left. So I think I'm going to, if everyone's okay, open the floor to questions from the audience. if you are able to just raise your hand and pick somebody that the question is directed to, so we can coordinate how they'll answer. If you have a question for Tiffany, then we'll have to get her on speaker again. So I can see that Robin's hand is up. So Robin, if you wanted to ask your question.
Yeah, I'm curious how like different organizations or entities that are currently operating and have serious clout in the TV space are performing in consideration of the TV language guide that's come out. So we don't have an actual traffic light scoring system down yet, but maybe that's something that we want to do as a next step as a community, but just general reflections from our speakers. So Rhea, maybe you can speak to some global actors like the Global Fund, TV Alliance, Stop TV, or others. And Elizabeth, maybe you, and Tiffany, maybe you can speak to your domestic experiences of how the organizations that are working in TV are doing in consideration of words mattering and reflecting that in how they work.
Thanks, Robin. Just in reflection to what, I mean, in response to your question, it's interesting because I feel like, every time we develop a document in global health, we're also tired of developing this document, and then dissemination is another, conversation we don't have enough of, right? But I'm happy to share that an organization like the Union, for example, the Union hosts the Union World Conference on Lung Health every year. And they have adopted the guide in their submissions. So you sort of, it's a point-based system, where they sort of, review your submissions, and you get negative marks if you don't adopt the guide, right? So I think that's a really, really important step. I definitely think, when the guide was launched in May, WHO showed their support. A lot of NTP managers from various countries showed their support. The private sector showed their support as well. So I just think we need to sort of follow up on that support and make sure it's actually like done. And I think the key is to ensure the technical agencies, who I'm happy to say are pretty quick to respond to these guidelines and are quite supportive. So I think it's a matter of just making sure that it is done.
I can speak to some of the ones that I know about. I was also involved in the writing of the Canadian TV Standards 8th edition that was released this spring. And I'm sure we did not do a perfect job, but we made a point of going through the standards to try and deal with the whole issue about stigmatizing and supportive language. And that was an explicit goal and process of the writing and editing of those standards. So I think that's the first time that we did it as kind of a conscious, organized effort for the whole standards, not just like different chapter authors may or may not have had it on their minds. So there's an example of a technical document that's widely used in the public health and clinical community in Canada, where we made an explicit effort to look at the technical language through this lens. I can say for the TV program in Toronto, those issues like changing the name of the program is something that we've tackled. We've also talked and this is maybe, I don't think it's specifically in the guide, but we also, it got derailed by COVID, but right before the pandemic, we had begun talking about changing the name of our DOT program to treatment support instead of directly observed therapy. Thinking about what was that program actually meaning to do, and what was it functionally doing? And so just sort of an example of being conscious of language. So I'll stop there, but those are two kind of specific organizational bits.
Perfect, thank you. So we just have a little bit of time, but I want to address this one question here that was from Francisco. So I'm assuming that this one's directed at Tiffany, so I'll let her answer this one. What are your recommendations when using this guide in Indigenous communities? Shouldn't we have an intercultural guide? Tiffany, can you hear me? Do you have me on mute? Okay.
Sorry, I do.
Yeah, there you go.
So an intercultural guide, I think that would be a good one, very complex, because we deal with many different cultures, and to think of a guide of such would be huge, I think, and very complex. As far as using the language guide, I think in the Indigenous communities, there's just being aware of how we're presenting ourselves and how we're using the language and educating the people and the workers that are there right now, like the nursing community and physicians, are the teams that we collaborate care with. As with TB prevention and control, discussing with them, that would be the only way. Because, like I said, now that I'm aware of this TB prevention and control care as opposed to control, I think that's something I would probably be using more. Because the people are already in a vulnerable state of not feeling secure with health services and what we are in an image for them. So just being cognizant of how I'm using my wording with and the language that I use within the communities would be the best defense, I guess.
Perfect. Thank you for that, Tiffany. So it's 9:58. Oh, sorry. So difficult. I'll pass it over to Akatha just to have some closing remarks and to close off the session today.
Thank you so much for that, Tina. And thank you all for that powerful discussion. I want to especially thank our panelists, and I want to thank Tiffany for sharing your story and your experiences with tuberculosis in Canada. To summarize, words do matter. It can harm, it can empower, and lead to action in the fight to end TB. We at Stop TB Canada strongly advocate for using shared and inclusive vocabulary. So in 2019, Stop TB Canada helped start a network of communities impacted by TB. And we initially called it TB Conquerors. And it has a colonial baggage to the term, but we had the title because some members in the community saw their journey as conquering TB. However, we've had to rethink the title given its colonial reference and implication, and the fact that colonial practices have been a major driver of TB stigma. So with this, we are excited to announce that TB Conquerors will henceforth be called TB People Canada. So you can join a network using the links Lee has posted in the chat, or by writing to us at tbpeoplecanada@gmail.com, or follow us on Twitter, Instagram, and Facebook. So please watch those spaces for more information on the group, which is intended to provide a safe space for TB-affected communities to share their experiences, resources, and to support each other. So thank you all for being here today for this critical discussion, and we'll be in touch with all of you. Thank you again, and stay safe.
Thank you all. Great being here.
Thank you.